Hey everybody, we're going to go back to old school a little bit. I know that there's been some issue with the voice skipping and those kind of things, so hopefully this will work a little better. I will upload the slides for you. So we're going to talk a little bit about the diagnostic coding or ICD-10 coding that is necessary um, for medical assistants to know. As a clinical medical assistant, you may fill in the front office sometimes. Also, you may scribe or you may have to work with the physician to help him finish up notes, take care, and kind of get things coded over for the visit. So there are there are three different things that will be necessary to know. One is the E&M code, and the E&M codes, there will be four different types of E&M codes. They're a 900 code, and those E&M codes are for an initial or a new patient visit, a regular visit, an extended visit, or a visit that has a treatment with it. So those are E&M codes. They determine that. But ICD-10 coding or diagnostic coding, diagnosis coding basically, it determines how we get paid. So it's very important because it determines how much money that comes in. And if you can't, if you don't understand that, then it's real difficult because we have to chart based on that diagnosis code. Our charting has to match up. And if it doesn't, then somewhere along the line it's been coded wrong. We want our assessment and our codes to kind of match. I'm going to skip past the learning outcomes. You guys can read those, and I'm going to talk to you a little bit about, like I already said, diagnosis, they translate to ICD codes. And for many years in America, we used ICD-9, and just a few years back, we started using ICD-10, and we kind of joined the rest of the world who've been using it since the 80s. So we were a little bit behind on that coding. What ICD coding does is it bases the reimbursement on the care that's provided. So you've got to understand what the codes mean, and you've got to know how to choose the correct codes. Especially for a medical assistant who works in the front office, you really have to know this because you may be checking over that before it goes to billing. And if the codes are wrong, technically fraud has been committed. And that's the last thing you want to do is commit insurance fraud. So you want your charting and you want your coding to be accurate. So the reason for diagnosis codes, most of our diagnosis codes are going to be related to the chief complaint. And there's going to be a diagnosis or a issue that is attached to that. It has to be medically proven. So we can't say someone has strep throat if there's not a strep screen done. That doesn't, or a throat culture done. We can have sore throat, but we can't say strep until it's been positively identified. And our charting has to prove the medical necessity for the treatment. So if someone had strep throat, we're not going to go and give them breathing treatments because they have strep throat. That would be a respiratory thing. So what the treatment that we give also has to match on those diagnosis codes. The other thing we have to do is we have to code coexisting conditions. What that means is maybe someone comes in with pneumonia, but they also have COPD, chronic obstructive pulmonary disease, and they also have congestive heart failure. We have to code those things as well because those impact that pneumonia. So we want to code coexisting conditions as well. So international classifications of disease codes for us for years was the ICD-9. Now the ICD-10 is used worldwide, and it is what is used to choose our codes from. In a little while, I'm actually going to show you guys the ICD-10 book, and I'm going to go through a couple of, we're going to look up a couple of things based on a scenario. You can also look codes up on the internet. It's very easy to do that as well. Okay, so the original purpose when the ICD-9 was originally developed back in the late 70s, it was for classification purposes basically the CDC, it helped the CDC collect statistics on morbidity and mortality. What that means is disease processes and death related to those disease processes. It helped with medical research, healthcare education, and also how we administered care. So that was the original purpose for the ICD-9. It ended up transforming into a payment system, and grouping diseases under certain categories. So that kind of developed over time, and now we use the ICD-10 coding system, which is much more detailed than the ICD-9 was. Reasons for diagnosis codes, why it's currently used, it facilitates payment. It also helps evaluation and utilization patterns. So when someone's in the hospital, oddly enough, there is a utilization nurse that goes around and reads their chart and determines if they are getting better or worse. And basically, based on their diagnosis codes, there is a specific number of days that a patient can stay in a hospital and the hospital not lose money based on that diagnosis code. And so their job is to go around and look at what's going on with that patient, to make sure that we are utilizing the money appropriately based on their codes. It also helps us study healthcare costs. Are there more people going back into the hospital because of congestive heart failure? So maybe we're not treating it right and we need to increase or change the protocol for treating certain diseases. So that's one of the things, the study of healthcare costs, how they study healthcare costs related to ICD codings, is it determines, we're going to have, if we have more people going into the hospital for a disease process, then we must not be treating it right. It also helps research. So if there's more issues with multi-drug resistant bacteria being in the hospital, more hospital admissions related to multi-drug resistant organisms, then we need to research and find new antibiotics that will kill those bacteria. Predicting trends. You can use it to predict trends. People are living longer. We're having more people with heart disease. We're having more people with obesity. We're having more people that are diabetic. We can see those predicted trends and then try to do preventative care to plan. Well, as we plan for the future of healthcare, we can try to develop preventative care to take care of those problems before they get significant. I'm going to skip past this because it's really loud. And it just wants to know, it was just asking, why we use ICD codes. I'm going to talk to you just a little bit about ICD-9 so that ICD-10 will make a little more sense. So ICD-9 came in 3 volumes. It had a tabular volume, which basically had little sections on the outside, and it was the disease and injury, and it had 17 chapters of disease descriptions and codes. It had V codes and E codes. V codes were treatment codes, and E codes were basically incident codes, like if someone fell. So V codes were like if you needed physical therapy or IV therapy or other kinds of treatment codes. Those were what those were. Volume 2 was an alphabetical index. So they were listed in alphabetical order, not based on disease process or system. And then Volume 3 was specifically for hospitals only. So it was set up that way. Now we have one very large ICD-10 code book that has about 68,000 codes in it, and they can be used in any venue of care. It also had an appendix where you could look things up. And oddly enough, the appendix normally in books is at the back, but the appendix in ICD-9 and ICD-10 is actually in the front. It helps you look things up quicker. Okay, so these are some things that you're going to see in ICD-9, ICD-10, both that did not change. You will have something called an NOS, which means not otherwise specified. Not otherwise specified basically means we have a condition. Here's a good example. I have a fracture of my the very tip of my fifth finger, the very tip of my pinky. Well, that particular part of the phalange is not coded, so that I would put fracture of the fifth finger NOS, not otherwise specified. It doesn't specify that specific location. Not elsewhere classified is more related to condition, so like renal failure or heart disease or congestive heart failure or COPD stages. Those would be the not elsewhere classified when things have stages. Cancer would be another one. If things are in brackets or in slant brackets, you need to read what's in there because it gives you something specific to look at, or it's going to give you specific things to pay attention to. It might tell you it needs another digit. It might tell you that it needs a subsequent code. It needs another code to go with it. So be sure you look at anything in any type of bracket. If it's in parentheses, if there are words in parentheses, it's going to mean that it includes all of those things. So if it is hypertension, essential hypertension, it's going to tell you that in parentheses it says it has a list, then it's going to include all of those things. But then it may have a colon after that that says excludes hypertension related to renal failure. And then it'll have a different code for hypertension with renal failure. So you would have to look somewhere else for that code. If there's a brace, then you're going to have additional codes that go along with it as well. So if I fall off of the bleachers and get a laceration and a concussion, I'm going to have to code, and I'll just look up concussion. I'm going to have to use an additional code to determine why I have that concussion. What was it related to? So you're going to use the first thing you're going to use is the code, what the underlying disease, identifying the underlying disease. Which is basically that chief complaint. And if applicable, you're going to use whatever code the real problem is. You want to be aware of anything related to that code that's in bold or it is italicized because it's going to give you more direction. So you want to read the whole section. And it'll make sense here in a minute when I flip over the camera and we look inside the ICD-10 book. The alphabetical index, sometimes it can so you don't want to just use the alphabetical index because sometimes, or the appendix, because sometimes it can leave off additional things that are needed for coding. Like maybe if you look at ear pain, and ear pain is R, and I'm just guessing because I don't know. I know it's in the R section, but I can't remember exactly where it's at, or maybe. Anyway, you're going to look up, and if you just look up ear pain, it doesn't specify right or left, but you have to add coding for the right or the left ear. So you want to make sure that you do that. So this is an example of the ICD-10 book that you're seeing here. You're going to see that it's blindness, if it's acquired or congenital in both eyes, it used to would be 369.00. If it's accompanied with deafness, you have to add that additional code of V4985. So that was what ICD-9 was like. Now I'm going to skip on a few more because things have changed, and we're going to look at ICD-10 coding, and I will make sure that the ICD-9 are gone by the time you get these that I have switched through. They will be gone. They were supposed to have already deleted, and I apologize they didn't. So let's talk about ICD-10. So ICD-9 came in the mid to late 70s, and it had 14,000 codes. There has been no expansion since that time. ICD-10 once again was developed in the 80s, and it has over 68,000 diagnosis codes. It's very specific, and there's room for expansion with it, and it does expand every year. And then there still is that IC10 PCS, which you can pull out just hospital codes. What I will tell you is no one ever knows all 68,000 codes. They just learn to use the book well. So it has that same alphabet index. It has a tabular list with 21 chapters. It has three category chapters. Chapter 3 is categories. Chapter 4 and 5 are subcategories, and up to 7 final codes for up to 7 chapters. So it's going to have sometimes multiple chapters depending on what you're looking for. Now, characters and specificity. So codes beginning with it, all the codes begin with an alpha character. So they all have a letter at the beginning. They have anywhere from 3 to 7 characters. Their ICD-10 is more precise clinical. It gives a more precise clinical picture. So when someone looks at those codes, they can tell a whole lot more about what was wrong with your patient and what you actually need to be paid for with ICD-10 as opposed to ICD-9. And also it helps to trend analysis of how patients are doing, improving, not improving, or as a bigger population becomes more ill. And if you'll look on the left and the right, the ICD-9 had very limited specificity when it said carcinoma of the breast, and the in situ basically means it's encapsulated. But it's just somewhere in the breast. It doesn't give you any location. Where ICD-10 has lobar carcinoma in the right breast, or it can be intraductal carcinoma, so it can say it's either in the rings or in the rings of the breast, or it's near the nipple of the breast. So it can talk about, it can specify even better, and it gives a better picture of what kind of treatment and things that can be expected for this patient. Now, sometimes there are X placeholders, and basically they are there for future expansion for more specific codes. We do not drop the placeholder when we add characters. The placeholders stay there. So if it says, like on the left, it's ICD-9 was a face, neck, or scalp abrasion. It didn't give any location, or friction burn without mention of infection. That was all one code. Anything you did to any kind of abrasion to the face, neck, or scalp was under one thing. Where in an ICD-10, we can look at each one. So an abrasion to the scalp, it also has to have that 7th placeholder where it says code noted for 7th place. And you're going to put an X, so it would be S00.01 X. And if it's the first time they were seen, which generally would be at the doctor's office or the emergency room, that very first time, that's going to be the initial encounter, and you would put an A after it. If it is going to be a subsequent encounter, which means they have to do follow-ups for wound care, then we would put a D there. A sequela would basically mean that they have had a gap in care but have come back again to be seen. So maybe they came and did their wound care, came to see them initially, took care of their wound care at home, and were coming for a follow-up on that abrasion, then that would be sequela. And I know it's a lot, but it will make more sense as we work through them. So there's also more combinations of codes that are, and it decreased the need for multiple coding. So septic shock and severe sepsis are one code now. Some things were combined where you had to code multiple things before, and they were in in alternative locations. Now you can find them in the same area. Okay, I'm going to click past, but this is what I want you to think about here. Basic coding knowledge. The thing you have to know is, the first thing you need to know is what's going on with your patient. When you know what's going on with your patient, then you're going to look it up in that alphabetical index. You're going to go back to the tabs, and you're to each section, and you're going to read the notes. Then you're going to follow the terms. Are there brackets? Are there parentheses? What are the directions that it gives you? And then you're going to read under it for any information that it says and give it the highest specificity possible. If you can say laceration to the right fifth finger on the distal end, then that's what you want to put, the most specific code you can. They want you to stay away from NOS and NEC codes as much as possible. It also affects payment to your provider. Other coding guidelines, the ICD-9 and 10 are similar in their conversions. They are not similar in numbering, but they do give you the ability to pull more information out of the physician's note to code it better. You never want to code from the alpha index. Like, you never want to code basically just from the front appendix. Verify all the codes in the tabular list, which are generally colored. Okay. So I'm gonna look a little bit, and then I'm gonna let you read the rest of these. But it goes through and talks a little bit about the different things that each chapter of the book codes. Chapter 1 does HIV coding. Chapter 2 is cancer coding, neoplasm. Chapter 4 is diabetes related. Chapter 5 is pain related. Chapter 6 is eye and ear related. Chapter 9 is hypertension related, and so on. And as we look at the book here in a minute, you'll be able to see more. But see, there's all 21. And so here we see an actual little section of the ICD-10 book. And so I'm gonna read some information, and we're gonna actually look it up. But this one is for osteoporosis. So if we were just looking up someone, an 85-year-old woman who had a shoulder fracture related to osteoporosis, we have to read all of these, because M80.01 is age-related osteoporosis with a pathological fracture to the shoulder. Now, we want to be more specific if we know that it is the right shoulder or the left shoulder. But if we don't know which shoulder, then we have to put unspecified shoulder if the doctor didn't document it. So we can't just do the .01. We have to use one of those other codes. We have to ask questions, we have to clarify, and we have to put the correct information for coding. What is this? When is the 7th code required, and what does it indicate? So it is that initial, subsequent, or sequela when it's been used. Okay, so this is just a summary. You guys can go back and look at that. I'm going to pause here for just a second, and I'm going to go flip the camera thing over, and I just want to show you a little bit about the actual ICD-10 book. So for just a minute, you're going to see a blank screen, or my board, and let me grab the book. Okay, I'll be, because I just want to give you a little bit of an example of what it looks like. So the first thing I'm going to show you is that this is a really thick book. It is a really thick book, okay? Now this is the CM Expert. You guys know I did home health for a long time, and so I used this when I did home health. There's also the PCS, which is hospital related, and it is actually bigger than this one. So when we look at this and we open it up, there's multiple companies that sell it. And as you can tell, it's a little bit out of date. I've had this since 2016. It's a little bit blurry, guys. I'm sorry. Let me back it up a little. Oh. No, it is all the way. Okay, so this is a 2016 to 2017 version, so it's a little out of date. But they're very expensive, so I have not bought another one. Now, when we open it up, in the very front, it actually tells you how to use the ICD-10 book. It's very specific. It tells you about the organization of the book, about the appendix. It tells you about abbreviations and the format, the typeface, like we talked about, what boldface does, what NEC, NOS, what inclusion terms and notes are. All those things that we talked about, it actually tells you about that in the front of the book. Then it gives you a little bit of an example of how the book actually works. And let me see if I zoom down a little. Hang on, guys. I'm going to see if sometimes it brightens up after just a second. It'll brighten up a little, but maybe not today for me. Let me see if I move the lamp over if you can see a little bit better. I don't know. Let me try. We've done that before too, and it helped a little. No, too much. Too much. Okay, sorry guys. It may be a little bit hard for y'all to see. I'm going to zoom it back out, and maybe that'll help some too. I'm going to send y'all, or I'm going to upload the 50 most common codes used in family practice. You'll need to learn some of those for your test. But it tells you how to look at. Now, what we're looking at here, this is just some reporting guidelines to tell you how to be sure that you are reporting things specifically, like pressure ulcers, BMI, things that are specific for documentation that are required by Medicare, CMS, Centers for Medicare and Medicaid. And that's what that is, general coding guidelines for each chapter. That's just how to use the book. Then we come over to the Index of Common Diseases. This is your alphabetical index. That is where you're going to go through and look for, say we want to look for abdominal pain. Okay, so I'm going to look for abdomen. So I've got abdomen right here, or abdominal, and it says to see also condition. So I can code abdominal pain, but I've got to code what's causing the abdominal pain, right? So I have abdominal pain, and it says underneath it I have acute pain, angina, and muscle deficiency syndrome. So say my patient comes in with an acute abdominal pain. Acute abdominal pain basically means it is not long, they've not had it for 6 months. It is something that is relatively new. And so that's going to be under R10-0. And so back here, these are my chapters, okay, the chapters that we talked about. They're also in alphabetical order based on the letter code when you look over here. So it said it is R10.0. So I'm going to go over to R, which for me is the orange tabs, 10.0. So here's R10.0, and it says acute abdominal pain, and it tells you under it severe abdominal pain. In parentheses, it says generalized with abdominal rigidity. That means that the abdomen is firm. Now, that means that includes it, but it also says excludes abdominal rigidity, generalized abdominal pain, NOS, or localized abdominal pain. So that if my patient had right upper quadrant pain, that's localized. That means it's in a specific location, and I need to go down below and look up pain localized to the upper abdomen, the pelvic or perineal area, or other parts of the lower abdomen. And then I'm going to find the right one, the most specific code. And I'm sorry, I was really hoping this would show up better for y'all. And I will make some copies of this so you can see it, but I'm also going to send you some of the codes to look at. So you're going to have that. So it says epigastric pain. It goes on to talk about if it's pain or tenderness. So you want to make sure that you're coding it the best way possible. Anyway, so that's what an ICD-10 code looks like. And you take the doctor's documentation based on what he says and what's wrong with the patient, and then you code it from one of these books. All right, you guys, have a wonderful day, and I will upload the 50 most common codes, also some CPT codes that we'll talk about a little later. You guys go over these, the front office reading, and go over the top 50 codes and kind of be paying attention to those, because I may ask you to look to be able to, and I'll let you use those top 50 codes, but you're going to have maybe a scenario or two where you have to use those top 50 codes to code what the scenario says. Okay? All right, you guys have a wonderful day. I will see you soon.